If you or someone you know is living with an eating disorder, today's conversation could be a potentially life-saving one. Our guests this week are Dr. Dena Cabrera and Megan Kniskern. Megan holds a Master of Science degree. She's a registered dietitian, a licensed dietitian nutritionist, and a certified eating disorder specialist supervisor. Big difference. For the past 15 years, Megan has been working in the field of eating disorders, substance use and disorder, and nutrition education. She has 8 years of direct care experience, 7 years of experience as a director and executive with various treatment centers and programs, and has been an adjunct faculty member at Arizona State University, where she has taught undergraduate and graduate level courses on nutrition, eating disorders, and addictions since 2015. Dr. Dena Cabrera is a clinical psychologist and a certified eating disorder specialist with a wealth of diverse clinical experience, including more than 24 years of treating individuals, families, and groups with a range of psychological and psychiatric disorders. Her specialized training includes neuropsychological and psychological assessment, dialectical behavior therapy, cognitive behavior therapy, eye movement desensitization and reprocessing, acceptance and commitment therapy, and polyvagal theory. Dr. Cabrera has served as the president of the International Association of Eating Disorders Professionals and currently is the IAEDP's past president and executive board member. She's also the co-author of Mom in the Mirror, Body Image, Beauty, and Life After Pregnancy. Dena Cabrera and Megan Kniskern, welcome to Next Steps Forward.
Thank you so much.
Thank you so much.
I had to look up a lot of these things. Some I knew, some I didn't. So please forgive my lack of knowledge, I'll say, in the space. And so I humbly, beg for your forgiveness on that. So let's start with a basic question, because I'm sure there are more than a few misconceptions. How do we define an eating disorder?
Well, I think it's a great question, and I'll come from a clinical perspective, as you know, our experience, and Megan will come from a nutrition perspective. And the good news is that Megan and I have worked together for a long time, so we've had a lot of similar experiences, and so I'm really happy to be with you today, Megan. In terms of understanding eating disorders, I think the first thing to remember is that there is the symptomatology that needs to be present to meet criteria for specific eating disorder, like anorexia, bulimia, binge eating disorder, or another type of eating or feeding disorder, which would be what we'd consider ARFID, which is avoidant food restrictive eating disorder. So there's those criteria of symptoms that need to come together to meet, to meet a diagnosis. But then there's this other, what we would consider disordered eating, which many, if not majority of those struggling or suffering do so in silent with this disordered eating that can take on different forms or different presentations, from dieting chronically to restricting or intermittent fasting, which is possibly affecting their not only psychological well-being, but nutritional well-being, and possibly medical. So there's a different type of eating disorder that really can be distorted in terms of the way they eat, their relationship with food, body image issues, and of course, their self-esteem. So all that to say, traditionally we have anorexia, where those who are restricting food and don't get enough energy and are way below or their nutritional needs, and of course are affected medically. And then we have bulimia, who are those who may be binging on a tremendous amount of food and then using compensatory behaviors such as purging it could be through self-induced vomiting or through exercise. And then there's the highest prevalent disorder, which is binge eating disorder, which is eating an enormous amount of food, possibly in a short amount of time, having loss of control, and not necessarily doing compensatory behaviors. So they can all get very confusing, but at the end of the day, I just want people to understand that these are very serious disorders and illnesses and have life-threatening effects. For instance, it's the second highest psychiatric disorder that leads to mortality. The number one is opioid addiction and abuse, overdose. And this is definitely the highest rated for mortality.
Megan, Dena just mentioned two eating disorders, anorexia and bulimia, and then she put in there binge eating disorder. Are there more types than just those three?
There are. And one of the fun things about being a registered dietitian in the space of eating disorder care is we're one of the only professionals that aren't allowed to diagnose. And so we have to be really familiar with the diagnosis and the criteria of eating disorders, as Dena mentioned, but we also operate within that disordered eating. They don't quite meet the criteria, but there's something significantly wrong with how they're utilizing food and how they cope with things. And so it is important to know all these. So we have anorexia nervosa, we have bulimia nervosa. Binge eating disorder didn't come in until about 2013, 2014 as it relates to being diagnosable. So this is considered more one of the newer in the sense of how we treat, how we utilize insurance, all of those technical pieces, but it is the most common of all the eating disorders. And that's really important to recognize. So binge eating disorder is the most common of the different types of eating disorders out there. It is typically most predominant with males as well, just something to kind of consider. Dena also mentioned RFED, avoidant restrictive food intake disorder, which is typically diagnosed in adolescents with failure to thrive, and sort of an extreme picky eating type of mentality is viewed in that regard. We also have OSIFED, I know, other specified feeding and eating disorders. And what I think is kind of important to recognize here is that most people don't fit into these criteria perfectly the whole time, right? They'll be having anorexic behaviors, and then they'll have bulimia tendencies, and then they'll have binge eating tendencies, and they'll go back. And that's not week to week necessarily. That's like month to month, year to year, decade to decade, as the body is fighting to stay alive through not allowing them to stay in those behaviors for very long, right? These aren't comfortable behaviors for the most part for most people. And so those would be the eating disorders that have diagnosable criteria. And then we have a whole slew of disordered eating, including something called orthorexia nervosa, which is, again, not a diagnosis, but a very, very well understood and more kind of research informed disordered eating criteria as well.
And Megan, you mentioned males a moment ago. We'll get to that later in the show,
Yeah.
but something I certainly wouldn't think of. And just staying with you, Megan, one more question. Are there different root causes for each eating disorder, or they stem from the same cause or causes?
But truthfully, they all stem from the same place. It's just how a person chooses to cope with that particular event. So we look at it. I was able to author on a paper that talks about the standards of practice for eating disorders for registered dietitians in 2020. So our governing board, the Commission of Dietetics, does a review every 7 to 9 years. And so we really took the research and identified 4 factors that can really emphasize a person's risk factor for an eating disorder, right? So we have genetics. There's a genetic component. We have environment. So like where you live, what's going on in that environment, what your culture, what your social environment is like, all of that. We have malnutrition. Malnutrition begets more disordered eating behaviors, right? And then we have this idea of temperament. What kind of person were you born like? I was kind of born sassy and a little confident and a little like talk backy, you know? So like things didn't come at me and impact me in the same way as a person who maybe came up and was born more shy, a little bit more insecure, a lot more self-deprecating, right? There's a lot of different features that can play a role. So when we have an event, and that event doesn't have to be an event we all universally see as being traumatic or horrible, an event we can't cope with, an event that we don't know how to handle, and we have these other factors that are sitting there, and it just kind of exacerbates this problem, because food is something we can control when we feel really out of control. And that within our society of healthfulness, as I air quote that for our listeners and non-viewers, and our obsession with body size, mainly thinness, those ideas are promoted through changing our controlled food behaviors in a way that makes us feel like that horrible thing that happened to us maybe isn't as horrible because we've got things in control somewhere else. So it becomes very distorted, but also very interwoven in the person. And that's why so many team members and so much support is needed.
Megan, you sound like my 16-year-old daughter, the way you were raised. This year at her high school soccer award ceremony, she received the award for sassy but classy. So
whoa,
I'll take
that. Yes, that's awesome.
She was very proud of that. I'm not quite sure how I feel about it, but everyone laughed when she got it, including the coach. So we'll live with that.
I love it. Quick caveat. I was the Where Are You Delta when I was in Tri-Delt for my sorority because I refused to go to all the boring meetings. So I took that as like, they know who I am, but I never show up for anything. So, it's all about personality styles and how we view ourselves. And then that has a huge impact on how these events cause us to respond.
And Dena, back to you. What methods of treatment are effective for anorexia nervosa?
Well, and there are various, and first and foremost, we would need a multidisciplinary team. So we would have a therapist, psychologist, psychiatrist might be involved, definitely nutritionist, dietitian, and also a primary care provider. So it does take a team in terms of an approach. And it's unfortunate, about 70%, 60 to 70% of individuals who do struggle don't have access to care. So I think that's something to just keep in mind. Ideally we would want this team, but in terms of treatment, definitely first things first is making sure that they're safe. So, in terms of like, if their behaviors, like in terms of weight, and there's medical or nutritional complications with malnourishment, we would want the doctor to, really work, and the dietitian to really work to stabilize them for safety from a medical standpoint. So that would be one component of treatment. Another component in terms of a clinical perspective would be, therapy, having a psychologist or a therapist work with them to basically help them learn the skills, again, safety first, but learn the skills to emotionally regulate, and also build resiliency and build hope, sometimes, often, that they can overcome the maladaptive eating patterns in replacing with the coping, healthy patterns. So that's really kind of in a nutshell. There's different approaches, like I know we'll get to some of that. But we always have to look at what's the first things first in terms of safety.
And rather than playing a tennis match and ping-ponging back and forth to you two, I'll just leave the questions open ended so everyone wants to
Sure.
answer.
Yeah.
How common are eating disorders?
Dena, do you know the current statistics? So
go ahead.
I mean, one person dies every 57 minutes is what it's at right now, I think. So one person dies every 57 minutes from an eating disorder. Prevalence was at like 8 to 10% of total population over lifetime. And I think it's up to higher, like 15% prevalence now. What we do know is since the 1950s, prevalence and occurrence has only continued to increase. So whether that is related to awareness of the disease and more people coming forward, because it isn't new. We've got dysfunctional and disordered eating practices that go way, 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 way back to the originations of medicine and medicinal practices. But in the sense of seeing it as a promoted disease state, seeing it as something that is ignored and having it be so interwoven in a lot of our other cultural factors, it's a really high prevalence rate.
So one person basically every hour.
Yes.
24 people a day, 365 days a year.
Yeah. And oftentimes it doesn't get categorized as, or the death may not be categorized secondary to an eating disorder. And so I think that's an issue as well.
You can't die of an eating disorder is what she's saying. So you would die of pneumonia, you would die of cardiac arrest or heart failure.
Yes.
So you wouldn't even, a lot of deaths wouldn't necessarily be identified in the statistical arena because we can't put a mental health condition on a death certificate. And so it's even harder for us to, even with substance use, you could put overdose, you could put, but you can't do that with an eating disorder.
Well, my next question for you was how dangerous are eating disorders, but you just answered that. I had no idea that statistic, so thank you for sharing that. I guess maybe more importantly, what are some of the warning signs of eating disorders?
I love that one.
Yeah, one of the first things I typically see, or, I always, caution parents to look for is dieting or mood changes. Now, that could be, mood changes, struggles in school, struggles at work, different difficulties, paying attention. Those kinds of issues can be attributed to other things as well, but you'll start to see, different behavior changes related to either approach to food, whether they're skipping meals, perhaps eating a lot of food that's different from their regular pattern of eating. So you're always looking for modifications, changes, shifts, whether it be in their approach to food or literally in their weight, or their mood. So those are the common kind of warning signs. But it's very hard to tell sometimes. I mean, it is a disorder of secrecy. I just had a parent yesterday say, I don't know where her weight was. I don't know. This is an adolescent. I don't know where her weight was. It's like all of a sudden it just changed. And so it can happen very quickly, and it can happen secretly. So there are, yes, safeguards, and there are ways that we would recommend to, how would you keep an eye on this? What would you look for? And definitely, mood, isolation, any kind of specific trauma that has happened or stressor that may, affect the child or the person. And any of those, sometimes just by sheer nature of trying to cope and function, nutrition or approach to food may change. Anybody who goes through a loss or a traumatic experience, their appetite or their hunger and fullness cues, or the way that they go about trying to just get through the struggle, their food and their mood is going to be affected. So those are always something to keep in mind, that we want to make sure the person is coping through these stressors in as best way as they can with regard to nourishment to their bodies.
I want to offer, if they're still in school, right? Great. Middle school, typically, high school, typically, those are when I see a lot of them coming in, and that's definitely the earliest time frame of susceptibility for these behaviors. But a few things to be looking out for too are any kind of bullying about their body, about how they appear, about how they look in any way, shape, or form. And not all adolescents are willing to talk to their parents about their struggles at school with social environments. If they sit with a community of kids that don't eat ever, right? A lot of parents will have their kids come home and just be like, I'm going to get healthy. And we all think, okay, great, they're going to stop eating, quote, junk food when they get home from school. And it's like, no, they kind of need that junk food as teenagers. Like, we don't want. So then they start buying some of those diety foods, some of the alternative foods, some of the fake foods. They go gluten-free, they go dairy-free, they go vegetarian. And there's nothing wrong with those things innately, but they're doing it just for the sake of doing it. They don't really know why or how. They've seen it or they've read it. And so it's taking what they're saying and pausing for a moment and saying, what is healthy to you? And what do you think that's going to look like in our home? And how, what are we trying to do here? Dena mentioned mood. She mentioned the food things. I think you can also, when she talks about the mood, there's a shift. Like when you used to talk to them a certain way, now they're like snapping all the time. Like everything's a big deal. Parents very much notice that there is a shift. And I want to emphasize what Dena said. Sometimes it can just happen. It's not like you're a bad parent. It's not like you haven't been there. It's just all of a sudden, one day you look at this kid and you're like, what is going on here? And I have 3 right now that have come over the last month to my practice that are right in that threshold of it can spiral really quickly, and it can spiral really quickly in an adolescent body that doesn't know how to cope with those changes. It is harder for those immediate changes as we get older in our 20s, 30s, and 40s, but that also means we get more desperate with our behavior, right? So it all has a space, but those warning flags really are, you can observe changes in your friends and your family members' mood, coloring, the way their face sits. There's definite concerns. And when you see someone struggling, the idea is to say, is there anything you need right now, right? It's not about fixing it or simplifying it. But we make lots of comments about people's bodies nowadays, and we have to stop doing that. We have to really expand our variety of what is normal in a body, because so many kids are susceptible to this because of the way that they're treated in a young body. And then that stays with them for a long, long time.
I think that's a good point. I want to piggyback on that in terms of our home environment, because we're probably, we're about a month and a half into the new year. And it's important to recognize that, everybody starts off the new year with New Year's resolutions and goals for health. And that could include dieting or working out or being more active. And I'm not to discredit that, but I want to be aware that oftentimes eating disorders start with that diet, let's get healthy, and then it's taken to the extreme and it happens quickly. So I want to be mindful of our attitude and approach toward food and weight and diets, in the home, because those messages can be very triggering to that could cause the start of an eating disorder.
Megan, I want to go back to something you referenced a moment ago in terms of adolescents and how they view their bodies. We've had some shows recently in terms of teen mental health and mental health generically, but you always talk about how Barbie, for 40 years, Barbie was, I'll say not the right phrase, pardon me, but the poster child of what a girl is, air quotes again, supposed to look like. Finally, Mattel has fixed that, thankfully. But a question for both of you, as we were in lockdown during COVID, I had 3 kids home from school. 2 were teenage girls. My son was 7 when we started. As they transitioned back into school, both of the teenagers back into high school, have you seen a spike? Megan, you just talked a moment ago about seeing 3 new patients this week. Have you seen a spike in the post-pandemic world as kids get reacclimated back into society?
100%. It got real bad in COVID. I literally opened my private practice, which I had avoided doing for years and years and years, in March of 2020, not knowing what was to come, and haven't stopped since then. It is a crisis, and it's a crisis that really no kid is able to avoid, because you bring up Barbie, but then let's add social media to that mix. That's Barbie times 5,000 on crack,
Steroids, exactly.
Right. It is a melting pot for perfectionistic viewing of images. And then we have parents and generations before current parents that have been fixated on weight loss and fixated on diets and fixated on looking a certain way and fixating on appearance. And you have those messages at home, and then you have those messages from society, and then you have your friends that don't eat, and your friends that work out, and your friends that are perfect, and really quickly, for an adolescent in particular, a young developing brain, that's too many messages to process. There's too much to try to navigate. So what I'm going to do is I'm not going to navigate any of it. And I'm just going to get as thin as I can so that people value me, and so that people like me, and so that I feel better. And so the more time that we really have in front of mirrors, the more time we have sitting with our thoughts and not feeling productive and functional, the more time that we have to question if we're good enough or we're okay, then the more that will exacerbate extreme behaviors. And again, we go out in society and people see us and then say, oh, you look so great. And they don't know that you're not eating and you're not doing all these things. And so you think this is good. This is what I've got to be doing. And it doesn't end unless someone intervenes most of the time.
Of course, no treatment obviously can be 100% guaranteed to succeed. What is the rate of reoccurrence for girls and women who are treated for an eating disorder, and does it differ at all according to the disorder, or for males who are treated?
I'm going to say 2 things, and then Dena, you can go. I'm going to say the statistic I know is 6 to 8 times in treatment for an eating disorder before a really solid state of recovery is not uncommon. Every time someone goes in, they take something new away from that experience. So to go to treatment multiple times is not uncommon. Also, the longer you have the disorder, the harder it is to get to a place of operating without the disorder. So decades in is going to be a lot harder to overcome for whatever we call that full recovery. Dena?
I agree. I think that in terms of, you were talking about the continuation, or the continuity of care, oftentimes it can start at a higher level of care, it can start at a lower level of care. It can also, meaning outpatient therapist, dietitian, to inpatient, 24-hour care in a facility. But that's exactly right. We see about a third of those. It takes, a few years, not to discourage anyone, but it does take time in an outpatient practice, and practicing new behaviors and learning, how to build your identity outside of weight, shape, and food.
We were talking before the break about males with eating disorders. And I suspect it's hard to know the answer to this question, but can we guesstimate how often eating disorders go undiagnosed and untreated for males?
We have a general idea, and this research is actually a little bit outdated, but generally, if you look, if you Google it on the internet, they'll give you a rate of about 10%. 10% of those diagnosed are males, but I'm here to tell you that is probably a very underdiagnosed or rate that they have come to us with, because I know, and even in the treatment center that I currently work with, Rosewood, and then also in my outpatient practice, I have males and it's more than 10%. So I think there's a stigma out there that still exists, that males do not get eating disorders, that it's a girl's disease. And I put those in quotes because I'll tell you that, eating disorders does not discriminate. They exist in all different body types, genders, ethnicities, from all, not just in America, from all across the country. And I think that's something to really be mindful of. It doesn't just look one way and in one specific, gender or population or ethnicity. It really is problematic, and they're very, serious. So in terms of males, though, one thing that you might see, again, if you look up, what is the profile, if you will, for those males who have eating disorders? And you might see those who maybe want to get bigger, like we call that, not a diagnosed term, like bigorexia, who are focused on, and obsessed with muscles in a sense. And that can be in itself its own disordered, lead to its own disordered eating with lots of supplements, and that could be problematic. And Megan can certainly talk on that. And then we also have another set with those males who may want this very lean body mass, and again, leading to its own compulsive behaviors around food. But in general, honestly, from what I've experienced in working with males, they're very much like all genders, like those in female bodies or all genders, that the underlying issue is very much the same. Fear, difficulties with weight, fear about, their body image, the underlying issue of maybe, some trauma or depression or anxiety. So the underlying issue is very much the same, no matter what gender, is what my experience has been. Yeah.
And I would add that Dena mentioned a lot of times males will be trying to gain weight and gain muscle, whereas females will traditionally be trying to lose weight, right, and look smaller. And so that becomes more of a risk, that we think, oh gosh, look how small that person is. And we don't often look and think, oh, look at how big and muscular unhealthy they are. However, there is a phenomenon happening right now in the bodybuilders world with very, very, very young sudden death. Somebody else just died recently, and I'm not even in that world, but it was a big shock to the world of bodybuilding. So we have to be careful, because with males, I need to ask, how many supplements are you taking? What kind of supplements you've done in the past? I would say that the underlying and the why isn't so different, but the way that it shows up and the way they're willing to talk about it, males, it does definitely have a different approach than the way that we initially work with a female. Males are more tends to be funny with food, especially at young ages. Like, a guy will eat a whole piece of pizza with his friends, like just to prove he could eat the pizza. And that's not disordered by nature, unless they're doing this every week or, or every day, and there's a problem. But it is really about looking at the dynamic and how they view food and how they view their body, in the same way that we do with females, and the way that they're malfunctioning and how they fuel and feed and care for their body. And as Dena mentioned, the stats are dated at 10%, but if we figure we see it at 15 or 25%, it really shows you the degree to which males aren't getting the same attention. And, you really have to think males didn't even come into the diet world until Atkins in the early 2000s. So men even being a part of this diet culture and a part of this fixation and focus on food and healthfulness is a little bit of a newer one than the female one, which is, goes back to statistically the 1940s. So it's just really different, but also very much the same.
Megan, a moment ago, Dena mentioned that the stigma associated with males, and you both talked about how, for the most part, it's males putting weight on and building body mass and building muscle. You touched a little bit on it, but are the treatment methods different for males with eating disorders and females?
No, they will be in treatment the same. They'll receive the same stuff. And again, it's more about how we as clinicians approach and talk about it with them. I will say that it's probably helpful to have mixed groups too, because then they can hear how other people talk about it and how other people relate to it. Because men, when I work with males, they don't understand that there could be an emotional connection to how they're using the food. Whereas us females are very much like, oh yeah, I know what's going on, or I'm numbing out purposely, or there's like a quick, with men, it's I would say just not often is thought out. It's just a lot more like, this is how I'm going to do it. This is what I'm going to do. This is how I'm going to follow through. So to have them in a mixed environment where they can connect a little bit more and hear others speak and express better is definitely one of the things that I've seen be really helpful for a lot of males in getting support and treatment in this environment.
And what is the best way to help and support someone who has an eating disorder?
Are you saying this from a clinician perspective or a family or friend perspective? Which direction do you want to go here?
All of the above.
I'll start, Dena, and then I'll kind of throw it over to you. So my first thing is, if you're a family or a friend and you notice something, you really have to go in knowing that they're not going to get better until they want to start getting better. And really forcing people into care. I know adolescents, it's different. They don't have a say, they don't understand. But the more there's a willingness, the better off someone's going to be, period. So coming in and saying, I see this, I'm worried about this, using lots of I statements, so you're not pushing anything on them, would be really important. And then letting them know that you're going to be there no matter what is always really important. There's a lot of fear of not being loved or not being liked if they don't have this eating disorder, if they aren't doing these practices. And so that can be critical. Dena, do you want to do clinical?
Oh, I'll try. Well, I was going to start with the parent perspective too. So I'll take off my clinical psychology hat and put my mom hat on. And, it's a really hard, very difficult thing to address with kiddos, even adolescents. So let's take about 19 and under. When you're seeing disordered behavior, or you're concerned about certain patterns that maybe have been exacerbated. So like over the holiday break, everybody hopefully spent some time with their loved ones, and you're starting to see changes in their behavior and their attitude toward food, or maybe even changes in their weight that you're concerned about. You don't want to focus on their body or their weight at all. In fact, it really is. The don'ts are, don't talk about your own weight, don't talk about others' weight, certainly don't talk about your children's weight. You're gaining weight, you're losing weight. It's all about, we really want to stay focused on balance and, health, if you will, and things that you may be concerned about. I'm noticing and I'm concerned is coming from that place. Like I'm seeing this change and I'm concerned about you. Because I'm wondering if it's coming from a place of anxiety or worry, or you're maybe eating out of boredom, so those are very delicate things, because we don't certainly want to comment on their bodies, because it's more about the patterns, and certainly not on a number. So it's very, take it from a mom perspective, it's really hard when you see a change, especially now you're going 19 and older, right? You have an adult child or a friend or a loved one that you're worried about. It's always coming from a place of compassion, like, hey, are you okay? I'm noticing that you're distressed, or there's been a change. But again, staying off what they look like, their weight, or, I noticed that you gained 30 pounds. You never want to say that, even though that may be, what you're concerned about. So it's more about the patterns. It's difficult. I say the first things first is getting them support, and, going in and talking to someone, because the earlier you catch it, the better. We don't want those behavior patterns to be entrenched for long. You want to try to break that cycle as fast as you can. Clinically, I always just say what I've noticed. I see that you're distressed. I see that your mood has changed. I'm noticing that you're isolating a lot. Let's talk about that. And how is that manifesting in your body or food?
I love I'm noticing that suggestion, because obviously it's not easy as a friend, a parent, a loved one, et cetera, to talk to somebody when you see something changing like that. And so I just think something as simplistic as that is just extremely helpful. So thank you for that simple phrase.
Well, it is. And I have 2 children who are adults now, really, they're adults. And behavior patterns has changed a bit, I've noticed. And I'm thinking to myself, well, I'm a psychologist. I know how to deal with this, but it's really hard when it's your loved one and you're seeing something that you're concerned about it. So I always take it from a place of, I care about you. And this is something that I think is worth paying attention to, because I'm concerned. I see a difference. Yeah. Not in their body. I see a difference in their approach to food, or I see their difference in that you're isolating more, something like that.
And how does someone know when they or someone they love needs inpatient treatment?
Oh, this is a great question. This is a hard question, because the first thing, so we do have criteria, if you will, for different levels of care. So inpatient definitely has criteria. If you look up at the American Psychiatric Association guidelines for eating disorder care for inpatient, there'll be a specific level, criteria for medical, nutritional, definitely psychological. There's about 10 components that they've included, which would be, where is their weight, where is their heart rate, for instance, nutritionally, how much are they getting in per day, how many times are they purging, for instance. So what are the compensatory, what's the intensity of it? So we definitely look at a continuum. Isolation, definitely mood issues with suicidality. So the more severe those 10 components are, if you will, lack of access to care, of course, if they can't get outpatient care, that's a concern. So definitely those criteria would indicate, what level of care they would meet, be helpful. But, those, any treatment provider who is a specialist or has an understanding of eating disorder will be, their job would be able to assess that and be able to determine based on the severity of symptoms. Yeah.
And Megan, that last question begs another question. How often does the person with an eating disorder know and accept that they need inpatient treatment, or any type of treatment for that matter?
They really don't at first. It does for a lot of people take a while to get to that point, because I go back to the fact that a lot of this is normalized by society, right? So they're like, what's the big deal that I only eat this much? I see these people eat this much all the time, or I see this all the time, so I think one of the greatest difficulties is, again, the normalization of disordered eating that we already have in our society. And that makes it harder for people who take those normalized behaviors and then go further to understand that that's not a good thing, that there can be a problem with being too focused on your health, right? And so a lot of times when that comes up, when there is just a strong fear, because that's usually what it is, right? Of having to go to that space, we spend more time building that rapport and building that trust and building that understanding that this isn't going to work for where you are right now. And usually that's already happened too. It is a very tricky game of chess to support someone, not only in their eating disorder recovery, but through the process that is eating disorder recovery. A lot of what we do as professionals is guide families through that journey. And a lot of what we do as professionals is know other professionals and other treatment centers and other facilities, because I'm never going to just think, oh, they're going to come to me and I'm going to fix them. I'm thinking they're going to come to me and I hope this works out, that we won't have to do something more, right? And so I will also offer, sometimes the parent is more fearful than the child. The child will be ready to go, but the parent doesn't want them to go, right? They don't want their kid to be away, which as a parent with 2 young kids, I get that. But then as a person who's seen eating disorders, I don't get that. And so it is very much a part of our clinician role to be in the trenches of these decisions with these individuals, so they don't feel like they have to navigate it on their own.
Right.
And Megan, you sort of answered my next question. You're talking about parents not wanting them to go. Are there times when parents just won't accept that their child has an eating disorder, even when it's obvious to professionals? And then what can that professional or concerned friend do in those cases?
Oh yeah, we see this
Yeah.
often in different ways. Go, Dena.
Yeah, it's I think there's a balance as a professional working with parents between, giving them the reality of why there's a sense of urgency because they are so dangerous, and also balancing with compassion and knowing how difficult this is. So I think that, I always want to caution on the side of safety, like I keep saying, about like, we've got to make sure they're medically and psychologically and nutritionally safe, and that oftentimes is a trip to the hospital, to make sure that labs are in order. But, my main goal with parents, because it is, like Megan said, is usually out of fear, either that they don't want to send, or it's a phase. I often hear that, like, this is just a phase, it's probably for attention. And I do a lot of educating about adults, and eating disorders. And that comes from the stigma of eating disorders. It comes from our society and our culture about messages about dieting. And it comes from our stigma about weight. And then we can go on a whole another show about weight stigma. But, we're so inundated that when someone tries, like a kiddo tries to get healthy, and it's gone to extreme, it just doesn't seem like really an eating disorder. How serious can this be? We're in this diet culture. We're used to this, so oftentimes what we say as professional is countercultural to what the media is telling us, or certainly social media. I just want to say one thing too. Did you know that there's over 900,000 messages, pro eating disorder messages on social media that kids get exposed to? There's a big campaign within the Eating Disorder Coalition to get big tech companies to regulate these messages, because it's really influential to our kids today. So I spent a lot of time, educating parents on the seriousness of eating disorders, what they're being exposed to from a social media standpoint, all the co-occurring disorders, anxiety, depression, suicide, that is prevalent with those with eating disorders, and then certainly about the nutritional aspect that is possibly affecting their growth and their health. So all of that together through education and persistence, hopefully they can come to an understanding that this is serious and we need to take action.
You talked about big tech, and at the beginning of COVID, I thought social media was the best thing for teenagers because it kept them connected and engaged. And now I can't do a Google search without seeing 4.9 out of 5 articles anti-social media and anti-big tech, to your point, because of what they've done. Mental health crises, suicide ideation, to your point about nutrition, eating disorders. And so count me in that battle for big tech, and we'll get to policy in a moment, but I totally agree with you. You've each devoted years of your lives, combined roughly 40 years, to the field of treating eating disorders. What drew each of you to invest so much of your heart, soul, time, and energy into a profession that doesn't always have happy outcomes, and all too often seems outcomes that end tragically?
Oh, I just got tearful. Working with patients with eating disorders has been just a privilege and a blessing, because I think for so many reasons. One is it's a complicated illness. And when you're in the trenches with someone who is really struggling and suffering. And then you see them start to, blossom and find the light, and you make little steps that certainly become big steps. And you see this transformation. I mean, it's so rewarding because I know they come from the depths of hell oftentimes. And so I think seeing that transformation and seeing that growth is tremendously rewarding. I think working with, those who struggle with eating disorders are the bravest people I've ever known. And I think that, inspires me every day. And honestly, I'm not just saying this, but recovery is possible. I also think it's rewarding to work with, a team, like working with Megan and coming together and brainstorming and tackling, the issue together, and working with a team of professionals has also been incredibly rewarding, because I learned so much. And every person who comes in the door, it's not like their eating disorder is unique. Of course, their story is unique. And it's not a cookie cutter approach, right? You have to figure out, that's the art of it, of figuring out, how am I going to help this person move forward? And everybody has their own story. And so together, we navigate that. And I think that keeps me invested so much in the work.
Dena, I get emotional on.
I didn't expect that.
Make me emotional.
My work here is done.
No, right. It's true, though. This is something, it is a passion. And I see people come into the field either having struggled in the past or having wanted to do this work, and they're here for a year or so. And then they think, nope, not for me, and that's fine. That's totally fine. That doesn't need to happen. Really, for me, it came down to, I connected to this more than I thought I did. I'm surprised I didn't ever acquire an eating disorder through my life and through my trials and tribulations in the food home environment I grew up in. And I find that, like Dena said, people can get to a place where they don't have to exist in a torturous mind fog of like having to control this narrative around food in your body all the time. And I think that it is a disease something everyone needs support around, because our culture promotes this dysfunction. And it's really hard to point that out to people. But once you see how much of this is out there, you can't unsee it. And so when I show up every day, I'm not showing up for work, right? I'm showing up to talk about and to support and to help things that I'm already passionate about to begin with. And so it doesn't ever really, other than notes, it doesn't ever feel like work. It's just a really beautiful ability to connect with people, and for a long period of time. And that's not just the clients, as Dena mentioned. We're a really big but really small community of providers, and they're some of the most amazing people on the planet. So we're just really lucky that we get to be included in these conversations.
Well, thank you both for the incredible work that you do. I truly appreciate that. We have about 2 minutes left, and I just touched on a moment ago. What policy changes do we need to empower communities and individuals to become aware of, prevent, and treat eating disorders?
Oh, we need more recognition from our government on the Hill. And we need understanding that there needs to be funding for research and training and education. That's kind of how I'll sum it up, because we've had different bills, if you will, to get funding. I mean, we've started with, in the military world, trying to get understanding and training in that realm and get funding. But I think we have a long way to go. Parity Act was passed. So mental health conditions such as eating disorder would be treated the same as medical illnesses from an insurance standpoint. But as far as funding for research, I think we're in the infancy stage and we have a long way to go. We really need standardized care. And we need data. And in order to open up those database, if you will, we need funding. So it all, comes back, but we need more of our legislators and congressmen and senators and governors to be understanding that this is a world health issue. It really is.
Dr. Dena Cabrera and Megan Kniskern, thank you so much for being with us today. And again, thank you for the very important work that you're doing.
Thank you.
Thank you.
I'm Chris Meek. This is Next Steps Forward. We're out of time today. We'll see you next Tuesday, same place, same time. Until then, stay safe and keep taking your next steps forward.